Welcome everyone to the October 2020 edition of the Pre-Hospital Care Research Forum Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. And here we believe it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. And here with the PCRF Journal Club, we take a closer look at some of the latest and greatest research happening in EMS. I'm Dr. Remley Crow, and I am joined by Dave Page, Dr. Tony Fernandez, Dr. Bill Toon, and Jeff Rollman today. It is also my great pleasure to welcome the authors of this paper, Dr. Brian Wilson, Dr. Natalie Akers, and Dr. Rebecca Jeanmonod from St. Luke's University Health Network in Bethlehem, Pennsylvania. Reminder for everyone, the name of the article we are reviewing is Pre-Hospital End-Tidal CO2 as an Early Marker for Transfusion Requirement in Trauma Patients. And this is published in early view, so hot off the press, in the American Journal of Emergency Medicine. As always, our discussion will be paired with an article written by our very own columnist, Dr. Tony Fernandez, in EMS World called Journal Watch. So we encourage you to go ahead and take a look at this article on emsworld.com under the category of Education and Training. I want to thank all of you for joining us today. As we begin, remind listeners that you can use the chat feature on your screen to type in questions and comments, and we're going to bring those into the conversation as we go. So hope to have lots of participation from you all. And with that, let's go ahead and get started. Doctors Wilson, Akers, and Jeanmonod, congratulations on your excellent study, and thank you so much for sharing your time with us today.
Thanks for inviting us, Remley, and team, I guess is the correct way to say that.
Oh, we've got quite a panel today. So, just to kick things off, I think it would be great if you all could introduce yourselves to the audience. I'm sure that they would love to hear a little bit about your background and experience with EMS and possibly how you got interested in EMS research. So, Dr. Wilson, can I start with you?
Yeah, absolutely. So I started off in EMS like most people did, kind of volunteering and working my way up as a volunteer EMT, then a paid EMT, and actually as of I think about 3 weeks ago, I officially became a paramedic, which is nice. I also went ahead and went to medical school, completed my residency in emergency medicine, and then did my EMS fellowship at Cooper University Healthcare in Camden, New Jersey. And just through the process of becoming a doctor and knowing I wanted to do academics and research was always just a part of that, and EMS was always a huge passion of mine, which kind of gave me my fuel for getting into medicine. It just kind of flowed, and then after a brilliant idea from Dr. Jeanmonod, we were able to kind of get this study going.
Awesome, an excellent road like many of us, not exactly straight to get to EMS, but here we are. And I'll go ahead and ask Dr. Akers, would you mind introducing yourself?
Absolutely. So I'm Natalie Akers. I am one of the second-year residents at St. Luke's in Bethlehem. I got my start in EMS kind of similarly to Dr. Wilson. Started out volunteering as an EMT as an early teenager, continued at all through my teen years throughout college, and then ultimately made the decision to go to med school because I just loved the aspect of medicine throughout my work in EMS. Went to med school. Now I'm a resident here working with Dr. Wilson, and that's how I became a part of this project.
And already diving into EMS research. I love it. All right, Dr. Jeanmonod, could you introduce yourself?
Sure. I'm Rebecca Jeanmonod, and I'm the Associate Residency Program Director at St. Luke's in Bethlehem. I am not a primary EMS person, but became involved in this project because I am very interested in trauma research. And so I do research with the trauma department and focused on pre-hospital trauma care as a result of being primarily interested in trauma research, and worked my way backwards to where it starts.
Fantastic. Love the diverse team here. So I want to thank you all again. This is awesome that you're sharing your time with us and able to talk about this excellent study, and I am really anxious to dive right in. So the objective of this study was to determine whether ETCO2 for intubated and non-intubated patients who experienced trauma in the pre-hospital setting was associated with the need for transfusion or operative intervention within the first 24 hours of hospital admission. But, before we dive into the methods and all of that, I'm always curious to ask authors, what is it that made you think of this study question?
Sorry, there we go. One of the things that I think really helped drive this is we always have this discussion of, especially at our hospital, did this person need to be in the trauma bay? Did it need to be an alert? And if it needed to be alert, was it the correct level of alert? We want to make sure we do the right things for patients, that we keep them safe, that they get the care to the bedside that they need. And one of the things that we always find, and I think most physicians and paramedics anecdotally will agree, that the vital signs are not a great indicator until it's too late, and then that's bad because it leads to bad outcomes for patients. And so we were thinking, are there ways that we can try to know which patients are sicker and truly need a trauma bay rather than those just on mechanism alone? Because as we kind of go into in the introduction, that the sensitivity and specificity of just the vital signs and mechanism of injury are not that great for truly needing trauma center services. So is there a way that we can make sure that we don't, miss anybody and appropriately get the right people there? And then in my mind, as we start looking at the future of EMS medicine, and we're bringing blood products to the field, and we're bringing, physicians and other advanced care providers to the bedside, to the site of the accident, and then depending on your scope of practice, if you're a paramedic and, just 911 crews, you can do that as well. What other capabilities can be deployed to them at that time if they're having low end tidal? Can they get blood bedside or pre-hospital? Can they get TXA pre-hospital, before we have confirmation that there's actually internal bleeding, by them either, becoming hypotensive or arresting?
Oh, I love this concept of identifying patients who are at high risk for mortality or in need of transfusion early. Looking for those early markers is just so important. And now I know the concept of trauma triage and identifying those patients has been a long-standing question in EMS, and trauma protocols vary. I think before we all got live here, we were talking about if you've seen one EMS system, you've seen one EMS system. And so I want to turn it over to Jeff Rollman. I know he had a few questions about how the trauma protocols work, not only in your system, but Pennsylvania has statewide protocols. So Jeff, I'll turn it to you.
Thank you, and thank you all for joining us today and sharing this great paper. Yes, my question was, since we have EMS professionals joining us from all around the country, even some outside of the US, I believe, we'd all appreciate it, I think, if you could just briefly describe first the Pennsylvania trauma criteria, and then the difference between a trauma alert designation A and B, which I believe exists at your system, and then also a little bit about your area in Bethlehem. Is this a fire-based EMS system? Is this private? Is this hospital-based? And then your kind of relationship with them. Thank you.
So Pennsylvania is one of the few states that has mandatory statewide protocols. So all EMS clinicians across the state operate under a shared system of protocols. And then as a medical director, I'm allowed to make a few tweaks here or there, but they're largely held intact, and we're not allowed to, make a separate set of protocols within our system according to how our state is set up. There's currently 3 main levels of care in this state. There's BLS and advanced EMT, like an intermediate level of care, and then the paramedic for the ALS level of care. And there's protocols set out for all 3 of those, and they govern everything from how do you respond to a scene, to where do you take a patient, to how do you manage everything from pre-hospital childbirth to respiratory distress to cardiac arrest to stroke. to hemorrhage control, and when you should call an air ambulance, when you shouldn't call air medical services, all those good things. And so here in the United States, and in our area specifically, this system that we looked at was an all ALS crew. So they were 2 paramedics that were on the ambulance that would respond to every call. We are a division of the fire department in this agency. However, they are all career paramedics and not firefighters. So we are basically like a civilian bureau of the fire department that, while we're very integrated as employees of the city, really operates as a third service. But our director does report to the chief, so it is technically a bureau of the department, not a separate third service. And then I, as the EMS physician for St. Luke's University Health Network, work as the medical director, basically in a contractor role for the city of Bethlehem, for the fire department, and for the Bureau of EMS. And so that's how I got involved with this agency. And then I'll let Dr. Akers touch on the internal level A, level B trauma alert stuff.
Yeah, so at St. Luke's Bethlehem, like you said, we have a trauma alert level A and a trauma alert level B. That decision is made by the emergency department physician that takes the command call. Basically, level A traumas are your super, super sick trauma patients. So what that does internally, it brings not only our trauma providers down, but we also have additional resources like blood that gets immediately brought to the trauma bay, anesthesia response for additional airway support, in addition to our emergency department staff. It also puts an OR on hold. So that trauma level is reserved for sickest of the sick. Our trauma level Bs, those are people that need to be evaluated immediately, but don't necessarily need those resources on standby at that very moment. So those are kind of what we consider like falls on. Blood thinners are usually in that level, your lower mechanism, motor vehicle accidents. And so that brings the trauma providers to evaluate and an emergency department physician to handle the airway, but not all of those other resources that those super sick patients need. So as you can imagine, that's not always an easy decision. We kind of face the same struggle that pre-hospital providers do in making that decision. Does someone need all of those resources on hold, or do they not? Obviously, you have patients that it's super obvious, but other times you hit this gray area. And it's a difficult decision to make.
Absolutely. And the concrete data that you all are providing is something, that's going to be very important for making those decisions.
Yeah, absolutely. It's one of the nice things about this, to try to, and obviously I don't think we're ready for prime time with this yet, but I think this definitely opens the window for asking some more questions of, can this be used going forward? And one of the best things about having these statewide protocols, with this level A, level B system that Natalie went through, is our internal trauma alert protocols are they're identical to what the statewide EMS protocols are, because they come from the Pennsylvania Trauma Systems Foundation as a statewide requirement, and kind of how the trauma centers have to operate in the state. So while at our institution we'll make the level A versus level B decision, it is pretty well spelled out in the protocol that we use in the hospital, which is identical to the decision algorithm that the paramedics use. And for anyone there, especially from across the country, if you're interested in the Pennsylvania protocols, feel free to just Google Pennsylvania statewide EMS protocols, and you'll find links to the BLS, ALS, intermediate, and statewide critical care transport protocols.
I always find it really interesting when there's statewide protocols like that. And I would, be interested in talking a little bit more. What are some of those components that the pre-hospital clinician is evaluating? Is it just what is in the CDC 2011 trauma triage criteria? Are there other things that are being taken into account physiologically, or is it based on mechanism?
It's based on all three. I think I'd have to put the CDC criteria in front of my eyes just to swear to it. but it very closely mimics the CDC field triage guidelines that were what I think that was 2011 was the last year that those were done, if I'm not
It
mistaken.
doesn't feel like 9 years ago, but yes, we definitely need this kind of research that helps validate it in a real world practice setting. So again, I think this study is just so awesome.
Nice. Well, thank you.
And now I think it is time to move into the methods because I'm a total data nerd and we promise there's no pop quizzes here. So I'm going to turn it over to Dr. Tony Fernandez to talk with us a little bit about your methods before we get to those results.
Well, hello, good afternoon. Thanks again for joining us today. I think this is a great study and I really appreciate you giving us some of your time. So we talked about your objective, and I think that a lot of this, your study is interesting because of the way you identified patients and you pulled records. As we talked about earlier, we have a lot of budding researchers who join our call, a lot of paramedic students and the like. And I'd really like it if you could walk us through kind of, in your methods, you state that patients were identified sequentially and that data were pulled or extracted by 2 physicians trained in the use of the system but not reviewing the records. Those are really important details, and I think I'm wondering if you can unpack that a little bit for our review or our listeners.
I think Dr. Jabino is our also in-house data nerd. I think you would be perfect to jump on this topic.
So I think that it's important to understand first how it came about that this was protocolized, and it was based on a pilot study where we had demonstrated in real life trauma patients that came in prospectively that end-tidal CO2 was beneficial and ultimately resulting in end-tidal CO2 being required. Most of our methodology in terms of our retrospective design were based on the change in the protocol, and we just aimed for 100%. We didn't have enough of a power calculation based on the prior data to really know exactly how many people that we were going to need to enroll in the study. And so we did this more as a pilot and attempted to enroll absolutely everybody. Our cutoff for end-tidal CO2 were based largely on a prior pilot study and then prior research looking at penetrating trauma and end-tidal CO2. And so that was our design. And then we had decided to do things like include people even if they were intubated because we thought that it probably wasn't going to make a difference because of the buffer system. And so that's sort of how we approached our design initially.
Yeah, I think that's great, and the effort, just for those who are on the call, it's a sentence in the methods. The data were extracted by 2 physicians, but that's quite a tedious endeavor. So I just want to make that clear to folks out in the interweb world. This is quite an undertaking. I think you all did a great job on it. So for the patient care reports, it looks like you pulled out your injury mechanism, some pre-hospital vital signs, as well as the capnography reading, intubation status, and then of course demographics and the trauma alert designation. And then from the hospital records, you pulled out the Glasgow Coma score and the trauma bay. You had the injury severity score, and you also looked at shock index. And I thought that these were some really interesting scores and measures that you included in your analysis. And I'd like it if you could tell us kind of why you thought that those were important for your analysis and to put these data into context.
Natalie or RJ, you guys can jump on that one.
We may have some folks on mute.
I can jump on that one. So
I was
Natalie,
just going to say, there are prior studies looking at those and looking at their cutoffs, and we thought end-tidal CO2 might have the opportunity to give a fairly objective measure entirely non-invasively and might just be a better measure because when you look at studies looking at shock index, when you look at studies looking at an isolated vital sign, they don't perform that well. And we just wanted to see if this was better.
Yeah, and the fact that the end-tidal CO2, you mentioned this, and I just wanted to highlight it. That's not something that needs to be calculated either by your software or by the individual. So I think it would be really useful if that's something that can be incorporated into decision making. So I thought that was really smart to include that in your methods. I think in your outcome.
can I just, I want to give a quick just comment to that one. So pre-hospital, when we did this specifically, because I had this question actually from 2 other people after the paper was published. So we used EMS data that was captured on the LifePak. The LifePak file was reviewed just to ensure that the numbers were accurate, that had come across from the first time that it was measured. Because Dr. Catherine Counts and her research associate Natalie Bulger from the Seattle Medic One program have really jumped into a super in-depth, way above my head analysis of end-tidal CO2, also in trauma patients. And they just, I know it was an abstract, I don't think the manuscript has gone through yet, published something in regards to that, where they really kind of parsed out the end-tidal CO2, did some calculations looking specifically at the waveform, and I just want to, give a nod to them for that super in-depth, awesome work, where we just kind of took to what you said, the number that was already given to us, something that we didn't have to calculate going forward. It was as it showed on the monitor.
Dr. Counts certainly crushes it when it comes to data analysis, so I love that. And I love that we're looking at, similar questions in different ways. So I think, if you're a new researcher coming up with an idea, it might be intimidating to say, oh, they've already looked at that, so we can't look at it. But, the basis of good science is replication. And so being able to look at the question from different angles and using discrete and continuous measurements is so important.
Absolutely.
I absolutely agree. And we say this every week, but I have the unenviable task of holding folks from the really interesting results to harp on some methods, but they really are important. So I'm gonna keep trudging along here. We've got a couple more questions on methods before we get to what everyone's on the call waiting to hear. So in your analysis, you looked at it. I thought it was a really interesting decision to decide to do a sub-analysis of younger patients where you excluded folks who were older than 65 from that analysis. 65 was interesting to me. There's some trauma research, particularly traumatic brain injury research, where they identify, and for those listening, this was not my decision, but they identify some geriatric patients as 55 and some even 50 and older. So it could be challenging to decide where that geriatric cutoff is. We see some of this in peds as well. Can you speak a little bit to how you determined that cutoff should be 65 for your geriatric population?
I think that I chose the cutoff of 65 just based on convention. A lot of the research that I do in trauma is head injury and C-spine injury related, and most of the research on geriatric patients variably give that number at 60 or 65. The reason we wanted to look at that specifically is that maybe not in our population, but in the majority of trauma populations, people are younger, and older people do have an increased risk of comorbid disease. And so we thought that there might be a difference based on underlying COPD and lung disease and kidney disease and that sort of thing. And so we wanted to look at the population that most people are seeing, even though we have an older system and do see a lot of older patients. But that number was largely convention based on studies and other related traumatic injury studies.
Yep. No, I think that's great reasoning to pick that. And sometimes with cutoffs like these, you have to rely on previous work and not just kind of use your default. And I think you've done a good job of that as well. I think that going through the methods, I think that the tests that you performed some Mann-Whitney tests, Pearson correlation coefficients, you ran some correlations, and some area under the curves. I think those were definitely appropriate for your data. You looked at your cut point was 35 for your capnography reading, and I think that that's very appropriate. But you did speak to the idea of looking at different cutoff values for ETCO2, and that's interesting. We've seen that in some other research recently, particularly with stroke scales and some shock index research. And can you speak a little bit to why it would be important? Because we know that capnography reading of 35 is quote unquote normal. Why would it be important to look at other cutoffs for that variable?
To every patient's end-tidal CO2 is going to be a little bit different. End-tidal CO2 is going to change based on many variables. The amount of dead space that a person has in their airway, which is going to be directly tied to how healthy their lungs are. If they're sick at that day, it's going to be directly tied to their underlying physiology, kind of like how Dr. Jamineau had talked about their respiratory system function, their renal function, those kind of things. So while 35 was normal, just tying yourself to whether it's quote normal or quote abnormal is just going to end up really affecting your sensitivity and specificity of the results that you get. If our goal here is to try to find something that performs better than the other trauma triage criteria that we currently have. So for example, the current trauma triage criteria use quote tachycardic, yay or nay, so meaning a heart rate of greater than 100 as being quote an abnormal vital sign. That could be in there. Same thing with respiratory rate, same thing for blood pressure, right? So if you have a smaller individual whose blood pressure might only be 100 systolic on a good day, if their blood pressure ends up being 90 systolic for whatever reason, it may not even just be hemorrhagic shock at the time. Maybe it's just, it's dehydration because it's the middle of summer and they weren't drinking a whole lot of water, and they get a higher level of trauma alert activation that can certainly cause a increased burden on the system, depending if, air medical services has to be used, or if it puts an OR on hold in most places. Blood products, could potentially become unusable if they're transported from a central refrigerator to the bedside if they're not returned in time. So there's the larger kind of opportunity and systems cost that could be lost, but obviously we still call those alerts because of the risk of harm to the patient, really. And that's what this comes to, is how can we help people and keep them safe and not cause any further harm. So as we looked at all the end-tidal values, what we really wanted to say is, okay, so 35 was normal. We're going to look at 30 based on this prior study. And then what we provided in our results was, well, yeah, 30 was fine. But in our group here, when we look, actually the highest sensitivity specificity, as we show on what I think it ended up being figure 1. Yeah, figure 1, the rock was actually 27.
And that was, I couldn't have, that wasn't a plan. I could not have asked for a better transition into our results though. So thank you for that. Yeah, again, I think the methods are really appropriate, and I think it's time to open the floodgates, and let's talk about your really interesting results.
All right, I love it. So let's go ahead and just take a look at Table 1, which is our traditional look at who was included in the study. But I want to talk about one step prior to Table 1, because you all did a lot of work looking at over 200 patients, but ultimately only about half of those patients actually had an ETCO2 value recorded. So I was wondering if you could talk a little bit about that. Was that something that's expected? Is ETCO2 routinely collected for patients with trauma that aren't intubated, and maybe should it be?
Yeah, great question. So this is a case study in process improvement science, which is very funny because currently working in the NAEMSP's year-long quality safety course, when we did these results, I kind of cried on the inside. One of the reasons why we ended up looking, and using our agency for this is prior to initiation of our protocol, my agency had a policy that says any pre-hospital alert, MI, stroke, or trauma, any patient who gets a opiate pain relief, any type of benzodiazepine, or has respiratory distress, or is otherwise desired by the treating clinician in the back of the ambulance, is to have the end-tidal CO2 applied. And so because of that internal policy, I was like, oh, hey, like we're supposed to be getting these on all the patients. As we published our initial, in Trauma Bay trial, that we're able to kind of pivot to start looking at this pre-hospital population. So this is really just a case study in process improvement science, that if you have a policy, it doesn't mean that people are actually going to follow it.
Wait, I want to
And so
emphasize that. You mean policies and memos don't work to change practice?
there you go. It's published. It's proof.
Proof right here. No, I love that. Let's say some more about improvement science, because I know this is a research podcast, but research and improvement science methods are so interrelated. So do you have any plans for how you could use improvement science to perhaps encourage more documentation of this variable, or how do you think you could change practice?
So one of the things after this that we did in our agency is we removed all but one nasal cannula from the ambulance that's a non-end-tidal CO2 monitor. So every nasal cannula that we use has end-tidal on it as a way to kind of suggest that they do that. And then the other thing that we've actually done is we tape one of the nasal end-tidal CO2s to the wall, kind of where the paramedic sits, as a kind of reminder of, hey, this is right here. Do you need to use this for this patient? I haven't pulled data looking at that after, but this was just two things that we did, are like almost like a mini PDSA, although we haven't done the S and the A after that mini change.
So for our listeners who might not be as familiar with what is a PDSA and that, let's talk about that. So when you're testing a change like this, you want to get higher compliance with something, instead of just rolling it out to every single ambulance before it falls flat, how are you testing these things?
So I literally was talking to two of our paramedics that are friends of mine after we had this data, and I think I was sitting in like the director's office, and I was like, why? And they're like, well, we have like other more important things that we're thinking about, like the patient. And I'm like, oh no, valid. Like, save a life as opposed to putting on a non-invasive monitor that at the moment doesn't have any direct, doesn't cause any immediate direct change in your treatment. So obviously, if they need to be bagged, bag them. If they need hemorrhage control, go for it. If you need to administer medications for whatever reason, that's obviously the true patient-centered interactions and interventions are really what we care about here, to make sure we get them alive and well to the trauma bay. But I said, what could make this easier? And they're like, honestly, we just sometimes forget about it. I'm like, cool. So let's make it a little bit more visible. And that's kind of where that came from.
I love that. So that's a very close to root cause analysis where, instead of just assuming it's because, oh, well, they just don't know better, I'll just send out more training and then they'll do it. Well, let's take the example of weight loss. Well, I know that I should eat right and exercise if I want to lose weight. If you give me a training course on it, doesn't mean I'm going to do it. But actually taking that time to go to the field level and figure out what might be leading to the results we're seeing and changing that is likely to have a much bigger effect. So I love that you're combining not only research, but improvement science here. And this is something that has a lot of application in EMS. Another vital sign that we see missing often is temperature. So sharing the results not only of research projects, but of improvement science projects are important as well, to say, hey, I'm experiencing something similar at my EMS agency. And I'm sure there are listeners on the call who are also wondering, how could I get ETCO2 recorded in discrete data fields more often? Another thing that I saw, and I'm not sure if you all saw in this project a lot, is that sometimes these values are only recorded in the narrative section of the paper, and it makes it really tough to run reports.
Yeah, and thank God that's one of the things we do really well with our agency, is that that these values do get in the discrete data field to pull. As we were looking at the NMS QA stuff for 2019, I couldn't pull stroke data because how we were charting, race scores or pre-hospital, or like the Cincinnati stroke scale, was a free text field, and I'm just like, I'm not wasting all of my time to go through every chart that's a stroke to try to find this. So we've tried to get that in a uniform way. So it's one thing that at least our agency does pretty well, that these values here go in the end-tidal discrete box we use EMS charts, as it says in the manuscript. So it goes in the specific end-tidal field for the vital signs.
Right, so important to standardize how we're collecting. And then that makes it easier if you were to do a multi-center study or something like that, then we can combine the data a lot easier than we would if, every agency collects it in a different way.
Absolutely.
And so we have the data that we have, and that is important. I'm glad that you all continued to analyze it, because this often sets the stage for bigger studies when we want to just dig into what was found. So there were 100 patients, which is no small number by any means. And you stratified table 1 by EtCO2 less than or equal to 30 and then EtCO2 greater than 30. I want you all to walk me through, was there anything surprising here, anything you'd like to call the audience's attention to in terms of the baseline characteristics of the participants?
Natalie, you can take that one.
Yeah, so I mean, I think the biggest thing with this table is just looking at your overall characteristics. So as we kind of alluded to earlier, we do have an older population that we see here at St. Luke's Bethlehem. Yeah, and more men than women, but still a huge number of women that we see in the trauma population. The other thing that I think deserves some mention is our mechanism. So we are a facility that sees a lot of blunt trauma compared to penetrating trauma. So I think it was, 60% of our mechanisms were falls. The next biggest thing was MVCs. And then, as I said, kind of on the lower end of that list is all your penetrating traumas. Other thing I think is just, obviously we're going to have way more level Bs than level As. So those are those less sick trauma patients. So the majority of the patients that were involved in this study, I believe somewhere around 80%, were those level B designations. I think those are kind of the biggest things to pull away from that table.
That's super helpful. And so what I'm hearing, and correct me if I'm wrong, is that in general, the population in that total column looks like what you would expect in your service area. So this appears to be a fair representation.
That's correct.
Exactly. Yep, for our area, this is about what we see on a normal basis. So obviously it can get a little bit complicated when trying to extrapolate that information and apply it to a facility that has a very different population.
Yep, and I think that's really good point. So I talk about extrapolation a lot, like, oh, are these results from this system likely to apply to another system? So this table 1 helps us really put that in context and figure it out. Another thing about table 1 that's not visible, but you all probably have some gestalt for, is were the patients who didn't have an EtCO2 reading somehow different from the patients who do appear in this table 1, or were they kind of similar?
So the anecdotally, I can just say this was not included in the methods. This is just from medical director data review craziness afterwards. A lot of the ones that we didn't have were some not as sick traumas. So the majority of the ones that we were missing were the not as sick ones. We did have specifically, I remember, 2 cases that did not have end-tidal CO2 that were very sick traumas, and they were, rapidly transported with BLS only airway interventions, and they didn't have any time to hook up an end-tidal or, use an iGel or an endotracheal tube for their airway management. So there were specifically 2 patients that could have been looked at with this, but we didn't have any end-tidal data for them, unfortunately.
It's so important, and it's good to have that knowledge of the system, because the first thing I do as a analyst of data is I do what I call the gut check. So does column 1 look like something I'd expect, and is there anything that could be confounding or confusing the effects that we're seeing? And in this case, it looks like pretty fair comparison. So I love that. Something else I want to call attention to in this table, as a consumer of the research, I scroll through these columns and I look for where are the big differences. So something that just stuck out to me is if I compare to the first column of table 1, which is the overall population, and then I look at that population who had the EtCO2 below 30, I can quickly see that these were sicker patients. The injury severity score, for example, is where I immediately focused in, and I said, well, there were 22% of patients in the EtCO2 group below 30 who had an ISS above 15 compared to 11% in the group. So it's almost double what the overall population was. And I think Dr. Akers did a good job at saying these were the really sick patients. So this is suggesting there is some value in that EtCO2 measurement, and even at this cut point of less than 30. So let's go ahead.
No, I was agreeing with you.
Oh, I thought I treaded on you. And Jeff, you look like you want to say something. Do you have a question to go
I had
along
a
with
quick
this?
question about the end-tidal CO2 measure before we move on. So I understand in your methods that you chose to use the mean end tidal value if there were multiple values recorded, and that definitely makes sense as a way to treat those multiple values. But I was wondering if that perhaps, I mean, if you're seeing end tidals trend downwards during the duration of a call in a very sick trauma patient, did you think about maybe looking at this analysis with the lowest end tidal instead of the mean? And maybe did that, or would that affect results and outcomes?
The reason we didn't do that is because in our pilot study, we had noted that some people had a very low end tidal CO2 at some point. And I didn't really come up with a great analysis for how to exclude the outlier, and especially if you just have two values. But when people hyperventilate, they will falsely lower their end tidal CO2. And so the lowest value was often not the last value, it was sometimes the first value. And so we thought it would be better to take the mean. And many patients did have more than one value. But I didn't see a clear trend.
That makes sense, and that's why it's great to have pilot studies to go off of, so thank you.
Absolutely, I can echo that. I think anytime we're able to test something on a small scale before rolling out all of our resources and energy, we get better information, and there's always something to learn before we take it to the big study. So great work on that. All right, I want to take a look at table 2. So this was the table that compared the different measurements, including ETCO2, but as well as some others, between patients who ended up requiring one of the interventions of interest, so transfusion or operative hemorrhagic control, versus those who didn't require an intervention. And I'll let the authors take this one. So what did you see in terms of which of these measures tended to matter? When was the median value different, and when was it not different for patients who actually required one of these interventions?
So the things that kind of stick out on this table, so end tidal CO2 obviously was the main thing that we were looking at. And we actually did see a difference just in this kind of gross data between those that required the intervention and those that didn't. So if you look at that table, the patients that required either a transfusion or needing to go to the OR, their end tidal CO2 was 25.5. Compare that to 31.9 for those that didn't need those two particular interventions. So when you do all your fancy statistics and everything, that becomes a statistically significant difference. The other values that we found were statistically significant were hemoglobin. I think that's useful in some aspect, but it's not something that we have immediate access to, like end tidal CO2. You can get an end tidal CO2 value within a few seconds of assessing a patient. Getting a hemoglobin, as useful as that may be, takes time. You have to draw blood, you have to get it processed by the lab, and that amount of time isn't trivial in a patient who's super sick and doesn't have that time to waste. And it also may not necessarily be helpful in those very first few minutes. You may get a false sense of security, if you will, with a hemoglobin that comes back within a normal range because it just hasn't had time to drop yet, essentially. Those I think are the biggest two that had a difference.
Also with a hemoglobin, you need to remember that since some people use hemoglobin as a reason to go to the OR, or as a reason to decide to do a transfusion, you suffer from confirmation bias, where including that as a measure, but it's also the reason why the intervention occurred, creates some bias in using hemoglobin as one of the comparators. End tidal CO2 is not currently used as a reason to do pretty much anything. And so it makes it a more pure value in that way.
I love it when we can bring confirmation bias into a podcast. You're after my epidemiologist heart. So I want to highlight that point, that the authors did not get sucked into confirmation bias looking for something that, is kind of a circular argument here, because that would drive the care. We would expect it to be like this. But why it's still important to include in the table, at least from my perspective, is that it shows that these values are correlated, that there's relationship between these variables, which again is quick gut check, something that passes that test of this seems like it all goes together and tells an important data story.
And then adding on to that, something else that I took away from this table, which I think was great, was looking at heart rate and systolic blood pressure. Those are values that we in the field often think about in terms of, is our patient in shock and are they compensated or decompensated? And I thought it was really interesting to see that that heart rate was pretty much identical between requiring intervention and not. And yes, the IQR on requiring intervention was a bit higher, but still neither were tachycardic. And looking at systolic blood pressure, yes, 115, a tiny bit below normal, but not at all anywhere close to that 90, which is often in trauma protocols, that marker of a physiologic criteria. So that just shows how we can't just look at these vitals alone, and how this end tidal and other parts of our assessment are so important. So thanks for putting this together.
Absolutely. And just one thing to echo kind of on our vital sign measurements here, I think it's important to remember this agency's proximity to the trauma center. Majority of the traumas will make it to the hospital within 12 to 15 minutes on the furthest end of town, and on the near end of town can be there in about probably 30 seconds to a minute, depending where they are in the city. So I think our average trauma transport time is somewhere in the range of 5 to 6 minutes, and so we tend to get patients early on in their injury, which is one of the things, especially here, where we might see them still when they're in their compensating stages of shock and haven't started to decompensate. And that was one of the kind of hypotheses behind the use of end tidal, is that would change before their physiologic parameters do. And that's exactly what we saw here.
And while we're on this table, I just want to highlight that when you excluded while the ETCO2 measure is, it kind of just slips over under that statistical significance bar. When you took out the geriatric patients, it looks like your medians went from were 25 compared to 34, and that was a little more highly significant at 0.01. So that just highlights how important it was for your a priori decision to exclude those geriatric patients.
Absolutely. And as somebody who's I'm not a 0.05 level person by any means, what I focus in on this table as well is that the point estimate. So, the median ETCO2 for those who required intervention was 25, compared to a median of 32 for those not requiring intervention. And so that means that 50% of all the patients who required intervention had an ETCO2 below 25. And I think that provides some important insight, and also provides some more validity towards that cut point of 30 that we were looking at in table 1. All right, now I do want to pass on to the figure here and take a look at the area under the curve analysis. I promise we're not going to do any calculus, but I think that it's really important to be able to interpret and look at these graphs and talk about what the implications are for practice. So as a quick primer on area under the curve, it can range from 0 to 1. However, area under the curve of 0.5 means that this is no better than a coin flip. Anything around 0.7 is considered pretty good discrimination for a scale, and then 0.9 and higher is excellent. So in this study, the authors found an area under the curve of 0.68. And now I'm curious, do you all know how this compares with prior work, or maybe any prior work related to other variables or other scores that are more complex?
Dr. Jomino, that is all you.
So I don't believe, and it's been a while since I've looked at it, but the other studies looking at end tidal CO2 and penetrating trauma, I don't believe that they reported out an area under the curve. And I am not sure about others based on the sensitivity and specificity analyses that we have for those same parameters in our study. They don't perform really great, but I would be lying if I said I knew what their AUC was.
Nope, I think this is super important. So, Dr. Fernandez and I recently looked at the ability of stroke scales to predict large vessel occlusion, and we were seeing area under the curve of about 0.68 as well. So I think that this is really telling that this is as good as a stroke screening instrument, and it's just a single vital sign that's easy to collect, no math involved. And so You know, when I talk about moving to a more advanced or more complicated score, like some of these that involve temperature, like the NEWS and the MEWS, for example, is the juice worth the squeeze? And in this case, you know, if I can get a 0.7 with a single easy to capture vital sign and I have short transport times, that says that maybe this is something I should definitely pay attention to. And so we do have a question from the audience I want to bring in, and that is related to that shock index. So this is another value that does involve a calculation. Is this something that providers are routinely calculating on calls, or is it displayed somewhere to them? Or is this kind of like an after the fact thing?
Specifically for this manuscript, we calculated the shock index after the fact. It's not routinely something that our agency requires documented anywhere, nor is it a parameter that we've tied into any specific intervention that we would or would not provide at this time. So thank you, Ron, for that question.
Excellent. All right, now I do want to ask a couple of questions for some of the newer researchers on the call, but first I'll make sure I've been talking a lot. So do any of the other panelists want to chime in before I plow forward? I'm hearing no objections. So
no, don't let her do it.
Perfect. One of the things I do want to talk about is that you all had some analyses planned, some logistic regression models, and you know, once you got the data, the sample size just wasn't amenable to a logistic regression model. And so instead of plowing forward with a statistical analysis that probably would not have provided meaningful results, you all held back and stuck with the descriptive analysis. Could you walk us through, was this expected or unexpected? And you know, how does this affect future planning? Are you going to continue this work?
So I think this was unexpected. I think RJ and I planned and hoped for a larger sample size that required intervention. However, you know, the data are what the data are, and we had to roll with it. You know, and that's kind of what it is. And we all felt that the data that we had was quite meaningful, even though we weren't able to do some of that more in-depth data analysis that we wanted to do, that we wouldn't scrap the study, that we still thought that it needed to be put out because it really lays an important foundation here to springboard into further research, which, yes, I think we would love to do. I'm not sure if Dr. Jomino has any other thoughts on that question, though.
So compared to our original pilot, which had a very small but prospectively enrolled sample, this was a lot more data for us, and I think that was very worthwhile. But keeping in mind that this data wrapped up a couple of years ago, there's so much more data out there to really solidify these results. So I think that we absolutely should continue the work, because you have an essentially free, non-invasive test that can change possibly actual outcomes, and how rarely do we really see anything like that. So I'd love it if we continued the work and got more data.
Oh, I love this. And I just want to echo what you both said. And I think this is important for especially new researchers who are starting out and might be intimidated by, oh, I didn't get the results that I wanted, or I didn't get the sample size I wanted, so nobody will ever take this study. Well, that's not the case. And this kind of observational data provides such an important foundation for telling us, you know, is this a research question where we should be investing more time and resources? And I think this first analysis definitely guides us in that direction. So I know we're winding down to the last 5 minutes here, and we do have some folks who are just getting started in research or just interested in it. And, you know, some things didn't necessarily go as planned in your study, but I would love to hear about your experience with the process of getting this paper to publication. And, you know, is there any advice for new researchers you wish you all would have known going into this?
Natalie is the newest one on the team. Would you like to jump on that one?
Sure. So it's definitely complicated. You know, it's been a long time since I was involved in any sort of research project. Granted, I was not involved in the data collection and that sort of, you know, very time-consuming part of the research process, but it was definitely a huge learning curve, kind of going back to how to write a paper and what kind of things are important to include and sort of walk through. And I certainly was not familiar with how to get a paper published, so that was definitely a learning experience for me.
Excellent.
And
So,
from my perspective, and Dr. Jamino will remember this very clearly. I went to St. Luke's as a resident, and now after fellowship, I've returned here into an EMS physician role and faculty role. And I very vividly remember talking to her during my interview about how research wasn't for me. Like, I don't really like research. Well, I don't like the idea of bench research. This study here, this type of research that really is very like patient oriented and very field oriented is definitely something that I would say is very interesting and very different than what I had previously thought research would be.
And I think that research in general is something that a lot of people are intimidated by. And I think that they vacillate between thinking that we have answers to a lot of the questions or we have no answers and they're hard to get. If you start with a simple question with a measurable result, you can figure out whether or not you can make changes. And I encourage people to try small, easy to answer questions on a small scale as pilots and then see if their ideas can be implemented in a more large scale. When it comes to publication, and this is, I don't know if this is the dysthymic me, but I believe anything can get published. I think that most of the time when people don't get their work published the first time, they give up. And I think that most of getting something published is persistence and polishing and believing in your idea and understanding how the process works. But there are times that you'll have a paper rejected 9 times, and then it'll get featured on Journal Watch, or then it'll get picked up for an award through ACEP or something like that. And so one of the tricks is to not be discouraged. I think that a big part of why research dies these sad, inglorious deaths is because people give up.
oh my gosh, I love that so much. So as a quick anecdote here, my first ever research paper that I was brand new and so excited to submit was rejected in 14 minutes flat. But I persevered, and I actually ended up turning that into 2 different papers that did get accepted eventually. But this is an exercise of persistence. I absolutely agree. I think there are a couple more points I want to pull out of what was said between these authors and their advice is that, the style of writing is really different than some of the writing that may happen in school. And so one of the recommendations I always have is just to read a lot. There are some open access journals available like JSEP Open for those who don't have academic access, but don't be afraid to read the literature. We're able to understand it. Yes, there's fancy statistical terms, but generally that doesn't change the direction of the findings. And then the other thing that was said that I think is really important is that this doesn't have to be bench science. You can take the data out into the real world and take it to different settings, and we need to be able to replicate and repeat. So we talked about how this study setting could be different than other EMS systems, and that there's definitely something worth evaluating here. And so we hope that it gets replicated elsewhere. And lastly, I really love what Dr. Jean-Monod said about keep it simple. It's especially with, electronic records these days, we have access to more data than ever. And so it's really tempting to put up every result known to humankind, but it's important to keep a simple research question and to stay focused on that for a research paper so that we're able, to do more research papers on the same topic, but with focused, direct questions. All right. And with that, I know that we are reaching the end of our time. I'll open it back up to our panelists one last time. Anything that you all want to ask before we go, or parting words?
I just want to say, this is Tony. I just want to say really quick, for any of you budding researchers out there who run into some roadblocks publishing your research, or if you just have questions, that's what the Pre-Hospital Care Research Forum is there for. So please reach out. There's plenty of resources on the website and the like. And I just want to congratulate the authors on this. Is a great study. I think it really adds to the literature. Thanks for joining us today, and thanks for getting this done.
Thank you for that, Tony. We appreciate it.
I just wanted to echo that this was a terrific study, and I like how you were able to move from your pilot study into this, and have future studies coming up. And as a policy wonk, what I especially liked is this was not research merely for research sake. This is something that could directly influence policy in the vein of trauma guidelines or clinical practice. So this is super relevant research. So thank you for sharing this and explaining it today and joining us.
And I will echo that thank you from the panelists today. is so great that you were able to share your time with us. And this study, again, we mentioned earlier that as more folks in the pre-hospital setting start to think about carrying whole blood, this kind of a study is really important on how can we pick out the patients that are most likely to benefit. So thank you to all of the authors one more time.
Thank you, Remle and Tony and Jeff. We, appreciate the invitation to join you. And, I'd be remiss if we didn't thank our EMS clinicians that are in the field every day, that were the ones who got this data for us, right? We kind of sat in the comforts of our home and pulled this information together and wrote it up. But day in and day out, they're the ones out there, saving the lives in the field and putting themselves in harm's way sometimes to do it. So, my so much gratitude towards them for doing what they do and trying to save lives and, get this data for us. So to all paramedics everywhere and all pre-hospital clinicians everywhere, thank you guys for what you do.
I love that. Yes, what you document matters. And so thank you all. And thanks for all of you who have listened. With that, I'm going to take us to our outro, which is, let's remember that we have the Education Research Podcast later this month. It's going to happen on Friday, October 23rd at noon Central. And we're going to be right back here with our clinical podcast on the second Monday of the month, which is November 9th. Thank you all again for your time and for listening and for your excellent participation. Look forward to nerding out with you all next time.